Dr. Nwange, if you are ready, I think you can shoot. Dr. Nwange, good morning. You need to unmute yourself. Oh.
Good morning, consultants and fellow colleagues. Sorry for the little hitch-up. Today I'll be presenting the topic of Friday's presentation. I recently discovered from the clinic register the number of people blind from diabetic retinopathy to be high. Discuss the steps you will take to develop a sustainable diabetic retinopathy screening service in your center. So I'll be taking it following this outline: an introduction, epidemiology, the pathogenesis of diabetic retinopathy, risk factors, screening and its principles, the health plan and implementation circle, and conclusion. So by way of introduction, diabetes mellitus is a major global health problem and is said to be a metabolic disorder of prolonged hyperglycemia secondary to insulin deficiency or resistance, leading to long-term multi-organ complication. The WHO divides diabetes into two basic groups, as the type 1, which is the insulin dependent, and then the type 2, which is the non-insulin dependent diabetes. So diabetic retinopathy is a condition with progressive retinal damage that occurs due to microvascular complication of diabetes mellitus. Approximately 1/2 of individuals will develop diabetic retinopathy in a lifetime, and the commonest cause of vision loss is diabetic macular edema. It said that within 15 years of diagnosis of diabetes mellitus, about 90% of type 1 diabetes and 60% of type 2 diabetes will have some degree of retinopathy. Sorry, I don't know if I'm visible. I can't see the usual screen by the side, whether the video is on, but I will still continue.
We
We
can
can
hear
see your
you.
screen.
Yes, but
Okay,
you are not using your video,
okay,
so we can't
okay,
see your face.
okay. So
Yeah, better.
the International Diabetes Federation estimates that there are currently 415 million adults living with diabetes, and this is projected to increase to 642 million by the year 2040. In West Africa, with a population of 250 million, it's said that 3.3 million West Africans have diabetes mellitus. And then diabetic retinopathy is said to be responsible for 4.8% of the 37 million cases of blindness due to eye diseases globally. In Nigeria, with an estimate of 6 million diabetes patients, 2 million are already said to have diabetic retinopathy. And it said that 1 in every 3 people with diabetes are said to have diabetic retinopathy. Globally, diabetic retinopathy is said to be the 6th leading cause of global visual impairment and a leading cause of blindness and visual impairment among working adults between the ages of 15 to 64 in industrialized countries who are said to be the younger and the more productive age group. And diabetic retinopathy is said to be more common in type 1 diabetes than in type 2. It's also said to be a sight-threatening disease. Being commoner in type 1 diabetes is said to be sight-threatening in about 10% of that type 1 diabetes. And then the proliferative diabetic retinopathy, it's said to affect 5 to 10% of the diabetic population as a whole. It said that the prevalence of diabetes is on the increase globally due to changes in lifestyle and epidemiological transition in most parts of the world. And it is estimated that about 50% of diabetics do not even know they have the condition until the later stages with complication. It said that diabetic retinopathy is often asymptomatic and puts the patient at significant risk of developing blindness from the disease. The natural history of diabetes and the availability of effective screening and treatment approaches justify the development of prevention programs. So just a quick insight into the pathogenesis before I highlight how I want to set up the screening services. like I said, diabetic retinopathy is a well-recognized complication of diabetes, and it's mainly a microangiopathy that occurs at the level of the capillaries. There are many pathways linked to hyperglycemia-induced vascular damage, which causes the damage and then the sequelae of what we see and then manifests eventually in the eye. So the pathways, the aldose reductase pathway, which causes which works via the polyol pathway, the release of advanced glycation end products, which further cause damage to the cells, the protein C kinase activation pathway, which will also release some antioxidants that will affect the cells, and the hexosamine pathway, which will also eventually lead to cellular damage. So it said that the prolonged exposure to hyperglycemia will cause damage to the retinal capillaries. And that is what I just have a diagram here to quickly show what I'm talking about. Once you have damage to the retinal capillaries, which are said to be where you have the diabetic retinopathy occurring, you have this initially loss of the pericytes. The pericytes are actually around the capillaries, then the basement membrane is said to thicken, and then sometimes you can actually have proliferation of the endothelial cells, and you also have damage to the endothelial cells. Then for the hematological changes, you notice some changes in the red blood cells, they become defective, the ability to transport oxygen is impaired, and then it's also known that platelets become sticky, and also there's plasma viscosity. The plasma viscosity increases. So all these hematological and metabolic changes will actually form the main pathogenesis for the features of diabetic retinopathy. It will lead to occlusion and then leakage. There will be leakage because of the loss of pericytes, breakdown in the blood-retinal barrier. So you have leakages, which will eventually translate as exudates, which we will see. Then the occlusion, because of the occlusion, you could eventually end up with impaired oxygen, retinal hypoxia, and then eventually you have the new vessels forming in the retina. Then this is just another diagram to actually show exactly what happens. What I just said, being a microangiopathy occurring mainly at the level of the capillaries, you have basically there's a capillary occlusion, and then you have microvascular leakage on this side. There's breakdown of the blood-retinal barrier. So you have leak. There's leak of the retinal hard exudates, which consists of lipoproteins, and then you could have edema, the retinal hemorrhages, which we all see are via this pathway here, and then eventually there could be release of vascular endothelial growth factor. On the other side, where you mainly have the microvascular occlusion, there's the retinal, because of the occlusion, there's impaired perfusion to the retina. So there's retinal ischemia, and then you have the release of the vascular endothelial growth factors and some angiotensins and growth factor hormones. And eventually the retina will respond by forming cortisone wool spots and capillary closure, avulsions, new vascularization. So these are just risk factors that would actually predispose one to having diabetic retinopathy. The duration of diabetes, that's the strongest. It said that the longer the duration of diabetes, the higher the possibility of progressing into a diabetic retinopathy. The glycemic control, how well controlled the diabetes has been, hypertension, hypercholesterolemia, nephropathy, cigarette smoking, pregnancy, obesity, anemia, intraocular surgery. All these are risk factors. Then just as a way of introduction to how to implement my screening program, like I said, diabetes is a chronic multi-system disease that requires multidisciplinary management and continuity of care. So in organizing a well-coordinated and well-documented diabetic care, I'll need to consider strengthening and reorganizing any health system. And the current services for diabetes need to be expanded with provision of effective integrated care, which includes case finding and management of diabetic retinopathy. Given the burden of visual impairment from diabetes, a well-planned, cost-effective prevention strategy is required, and that is what I intend to use. And then that will emphasize the need for screening, because if it is made accessible and affordable to the population, there will be early case detection. So key to implementing my program is the formation of a team. So in my team, I would want to have a diabetologist, as an endocrinologist, an ophthalmologist, the public health physician, the family physicians, and optometrists. Those are the key. I will have other people on board to work with too. Then I just want to emphasize, knowing that screening is going to be my major major way of going about implementing my program, I just wanted to give us a little definition of screening and the principles of screening. In medicine, screening is said to be a strategy that is used in the population to identify the possible presence of an as yet undiagnosed disease in individuals without symptoms or signs. And WHO defined it as a presumptive identification of unrecognized disease or defects by the application of test examination and other procedures which can be rapidly applied. It said that screening tests actually sort out apparently well persons who probably have a disease from those who probably do not, but it's not intended to be diagnostic. So I'll just run through the principles of screening so that this will help us agree with the fact that the diabetic retinopathy actually qualifies as a disease that should actually be screened. That the condition you're screening should be an important problem. There should be an accepted treatment for patients with recognized disease. Facilities for diagnosis and treatment should be available. There should be recognizable latent or early symptomatic phase. There should be a suitable test examination. It should be acceptable to the population. The natural history of the condition, including development from the latent to declared disease, should be adequately understood. There should be an agreed policy on who to treat as patients, and the cost of case finding should be economically balanced in relation to possible expenditure on medical care as a whole. And case finding should be a continuing process and not a one-time project. So based on this, I'd like to actually look at how I intend to plan the program and implement it. So I have an implementation circle here. This just helps me to actually outline what I intend to do. Deciding where I am, that's more like a situation analysis of the need and resources, which I'll talk about later. I need to know what is on ground, what the needs are, and then what resources I have, if that's all I have to be start the diabetic screening program. Then I need to decide where I want to be. That's my aim, priorities, and objectives. I need to decide how I want to get there. That's the plan. I need to have a plan, a timetable, and a budget. And then how do I intend to get there? The resources I need. I need to have continuous evaluation and monitoring to help me be on track. And then as I continue, if problems arise, I need to know what to do. So this was the health circle, actually buttressing what I just said. Identify the health concern. What's the problem? In this case, they were having not a high number of people going blind from diabetes. Then conduct health needs assessments. It's already been told in the register that I have a high number, but then I would need, outside that, I also need other things to actually have enough evidence to be actually put my case, so that even if I have to meet the government for funds, they will listen to me. I have to design my program, then I have to implement and then go on with evaluation. So for step one, which is the situation analysis, this includes assessing the need and priorities for the screening service and identification of a clinical lead. So like I said, I have a team who I'm going to put in place to actually help me through the program, because it's not a one-man thing. So I'll find out the exact number affected with diabetes retinopathy, the age group commonly affected from the available statistics I have in clinic. But outside that, I'll also want to know, they get data on existing manpower, those on ground, if they're always available as residents or they visit. I want to know the attitude and belief of the patients coming to the clinic, what they think and believe, their attitudes and belief towards diabetes and its complication, and their willingness to even render themselves available for treatment. Then being in a community, because the hospital is not an isolation, it's not in isolation, I would want to also assess community participation by finding out their access and uptake to existing eye care screening services that are available. Do they have any constraints or barriers to the use of the services? They would like to know. That way, I would actually want to know if the community is actively involved. Then that's just one way of getting my data, even though the question has provided. Another way is actually to look through epidemiological studies, and most of them have actually found diabetes retinopathy to be high amongst the leading causes of blindness after cataract. So that would actually be another strong point I would have in case I have to solicit for funds. Then it's also another source of information. Many programs under investigations actually show that a high patient load of late DR all see screening as a natural solution. There's many programs that have been instituted have actually seen that if screening is effective, they'll be able to fish out diabetic retinopathy on time and so forestall the issues of visual impairment. So with this, I'll be able to extrapolate and demonstrate the likely scale of the problem and then assist projections in mobility and blindness reduction if at all I'm going to present my case to the government needing help in terms of finance. So this is just, they're just blocks actually buttressing the need for having a situation analysis. It says it forms the first step of a planning, often the first task of a newly formed management team. You can bring the different types and categories of health workers together in a team building exercise. And it helps to document the problems and propose strategies that can be used in monitoring and evaluation. It can form the basis of the district health plan and health report, and then subsequent reports can be upgraded. Then it also identifies gaps in the information that is available and contributes towards the development of the health information system. So for the step two, having had this evidence from all I have said, I would like to advocate and partner with people like the government, knowing that I'm going to need funds, any private sector, any NGOs, the community as a whole, any research institution interested, banks and any other stakeholders. I would need the political commitment from the government through the Ministry of Health, National Eye Care Program, if it's possible for us to integrate this screening service into what is already available to reduce costs. Then also I'd like to look from the community aspects so that I can actually make it something, place the program in their hands so that they see that they are part of it and so are willing to cooperate with me. Then collaboration, it's not, since diabetes is a multi-systematic problem, I cannot do it alone. I actually need to work closely with the endocrinologists and the other high-level stakeholders, those in internal medicine, those in records and information because of the referrals at some point, those in general outpatient and even the public health department. Then I would want to set my objectives, which is basically to prevent retinopathy and related visual loss, specifically in University of Abuja Teaching Hospital, and then also to reduce the risk of sight loss amongst people with diabetes by prompt identification and effective treatment, if necessary, of sight-threatening diabetic retinopathy at the appropriate stage during the disease process. Then I'll need to assess my resources, the manpower and personnel available, how many retinal ophthalmologists do we have available, how many ophthalmic nurses are trained, optometrists, endocrinologists, the primary care physicians, do I have photographers, technicians, the photographers that will help to take the pictures, the fundal pictures, which are mainly used during the screening periods. Do I have biomedical engineers that will look into any technical problems, and then the record staff that would actually help if there are cases of referrals to. Then I need to look at the equipment and infrastructure available. It said that the two-field mydriatic digital camera is actually like the standard for diabetic screening presently. So if I'll need to see if I have one or if I have to get one. Ophthalmoscope, stick lamps with accessory lenses, if there's an OCT available, if there are laser machines for treatment, if I have a generator in case there's power failure, the medical consumables, my Snelling's chart, which I would use during the visual acuity during the screening. Like I said, I also need to have a budget. So my budget will help with direct cost and indirect cost. Direct cost will be the training and employment of staff, procurement of drugs, and the equipment I'll need. And then the indirect cost could actually be payment of staff salaries or all those that will be involved. Then for the service delivery mode, I actually would want to use a combination. It said that diabetes and retinopathy screening can be delivered using the static or outreach sites, or you can actually combine both of them. So for the overall aim is actually to choose that which is affordable and not very expensive. So the service delivery approach should be that which will reduce multiple appointments for patients and administrative burden to providers. So the static services, for the static services, it will be stationed probably maybe in the hospital there, and then I have people coming regularly to actually assess the services. And if I choose to work, combining with the outreach services, I would use a variety of facilities and then bring in staff and equipment and supplies for limited time. The outreach service actually entails going out using your vehicle, you choose a particular place, you go do the screening, maybe in the community or anywhere you have actually chosen, and then you can actually send your reports. That's why the software is also very important. Send whatever pictures you have or refer those that actually have been known to have diabetes or you think are at risk to the clinic. So clear protocols will need to be put in place for the management of those that have poor quality images. Because if I'm not able, some people may have cataract. So in the field, if I'm not able to actually have good quality images from the fundal camera, I may need to refer them to the hospital for slit lamp biomicroscopy. Then also there's the use of telemedicine fundus photography, which if I have money, I'll be able to implement. Here it said non-mydriatic fundus cameras operated by health personnel. These pictures are taken and sent by email to the fundus photograph reading centers, and it saves the patient a lot of time and trouble. And then he or she can actually cooperate with you. He sees what is happening in his eyes, and then he's able to cooperate better with you. So for implementing this, having all this as a background, all I'm trying to do is actually identify persons that are at risk of visual loss due to diabetic retinopathy, which is like my target population. So once I identify them, I'm going to make available an adequate referral mechanism so that all the patients with diabetes mellitus that have been screened will access eye care in case they have any possible eye complications. So while during the screening process, any patients with any level of macular edema, moderate or severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy will be promptly referred to the ophthalmologist. Then in the clinic for diagnosis and treatment cases, I'll need to ensure that I have there are accurate methods for detecting the presence or severity of the diabetic retinopathy. I'll need to ensure that there's a clearly defined standard national or international clinical guidelines that I can use to evaluate and treat these patients in a cost-effective manner. Then I'll need to provide follow-up care for these patients by making them aware and motivated. That way they are eager to actually see themselves being followed up, come for follow-up when due. And then I'll also, for the clinic, I just make sure that the place is well equipped so that the patients who are referred actually get what they want. Then still emphasizing the role of professional integration. It's not a one-man thing, so I need to work closely with the other departments. So I'll provide probably a weekly reliable service will do. And then there'll be strict structuring of patient flow between the ophthalmic and diabetes department so that the patients will not be subjected to the stress of having to open folders when they come. So maybe from the screening center, they can just be given pamphlets. When they come to the eye clinic, it just qualifies them to walk into the eye clinic and have the screening done. Then as part of my program, I would also want to educate and counsel, because this is very key. If they understand what exactly is happening and see the sight-threatening possibilities, they will be willing to do all that is necessary. I'll need to tell them that, I'll need to explain to them generally the cause of the pathology. It said that type 1 diabetics who are 10 and above should have a comprehensive eye examination by an ophthalmologist within 3 to 5 years of onset. So if I'm seeing anyone in this age group who has this, I'd actually tell the person. Then any type 2 diabetic patient who is being diagnosed, at that point of diagnosis is supposed to have an eye examination done, and then subsequently, depending on what is found, maybe an annual eye examination. And any gestational diabetic patient that is seen, I'll have to screen and then also educate them that at every trimester they should come, and then 6 weeks post-delivery they should come for screening. Then I'd also like to create a diabetic register, and then from time to time, like I said, I'm going to have a weekly service, so that will actually be the basis of my screening. So having a diabetic register, I could have the register in GOPD, in internal medicine, in the community, in the community health centers and some local government areas, so that anytime they see any diabetic patient, they can actually register the patient. And then once the screening service is going on, they can actually call can actually call them to come for the screening. That will also help to improve the coverage of existing services. Then another way again is, okay, once they've written their name, actually, I could actually send out notices to them anytime I'm going to screen. Then another strategy I would use would be to identify undiagnosed diabetes in the community. That is still related to the screening. And then with the help of the National Diabetic Retinopathy Program, I would try to advocate that more attention is paid in terms of creating better public health education and having awareness campaigns in the media, letting people know the dangers of poor sugar control, advocating for good medical seeking behavior as opposed to self-medication and herbal treatments if the patient has any problem. And generally, as this service is being rendered, there'll be need to generate and disseminate knowledge. Whatever is happening, I'd like to collate data and actually let people know that this is what is happening, the progress and all, and that way they're able to cooperate, and even the source of fund which I'll be getting, my sponsors will actually be happy. So the indicators that I'll be using to monitor for evaluation, to monitor and evaluate will be this. There are many more, but I just chose this. Knowing the proportion of known eligible people with diabetes that have been offered an appointment for routine digital screening, the proportion of people with diabetes that have been offered an appointment for slit lamp examination before their due date, the proportion of eligible people with diabetes who have not attended screening the previous 3 years, proportion of pregnant women with diabetes that are seen 6 weeks within notification of their pregnancy to the screening program, the time between routine digital screening event or digital surveillance or slit lamp biomicroscopy and issuing referral to the hospital eye service. Then an indicator for assessing my coverage of services will be the percentage of diabetic patients who undergo annual eye examination and those with diabetic retinopathy who have been treated with retinal lasers. Then as my program is ongoing, I'd like to monitor the program against a set of quality assurance standards. I'd like to monitor the program against a set of quality assurance standards because that's key to seeing the success of my program. And it said that until desired goals are met, monitoring helps to strengthen the program in areas that are not progressing as quickly as expected. I'll also want to do a quality assurance standard and key performance indicators will be used to a quality assurance standard and key performance indicators are important to reduce the probability of error and risk. It will also help to ensure that errors are dealt with competently and sensitively, and then it will help the professionals and organizations to improve daily. Then to see that my screening program is being sustained, there will be need for continued advocacy to maintain commitment to diabetic retinopathy screening services, as this will help sustain a comprehensive prevention effort and collaboration. Then the monitoring and evaluation aspect is also key so that I know I'm on track, so I don't lose out from my aim of trying to prevent people from turning blind. Then the team of experts who will be on ground will have to actually there'll be a forum where they'll need to constantly exchange expertise and experiences constantly so they can actually improve in their services. I actually did not see any national guideline but for Nigeria, but I was able to see this national guideline from the UK. It's they classified diabetes retinopathy, and then they had the UK National Screening Committee that was based on photograph guidelines, and this is what they came up with. For a patient that has no diabetic retinopathy, it was advised that they have annual screening. If there's any background retinopathy detected, like if there's any microaneurysm seen clinically, any retinal hemorrhages, any exudate seen, it's advised that annual screening be done. For patients with proliferative maculopathy, those that have had photocoagulation or any other lesions, are to be referred immediately to the ophthalmologist for treatment. So I was hoping that while the screening program is ongoing, I'll actually have to come up with a national guideline before the screening committee so they can actually know when to refer. But in the meantime, I could actually adopt this while I wait to get the one for Nigeria. Though we have the abbreviated early treatment diabetic retinopathy study that is being used globally, that actually classifies diabetic retinopathy and advises on how to treat. The shortfalls are that it actually, you need a series of about 7 field pictures of the fundus for each eye. So it's a bit not very convenient to work with if you're actually going to have to do a screening. Otherwise, this is actually the best classification for diabetic retinopathy, seeing that it tells us the stages of, it gives you a natural history of a diabetes patient with retinopathy who has not received treatment. So in conclusion, the key points in preventing diabetic retinopathy blindness is early detection of asymptomatic retinopathy. And the most important aspect of this is screening for diabetic retinopathy in the community. It should be a public health issue and is considered as such in industrialized countries. Primary care physicians should be taught how to perform fundoscopy also and the benefits thereof, and this should also be emphasized in the medical school. These are my references. Thank you.
Okay, Dr. Nwangi, well done. That was quite fluent. Well done. A good trial. So I think we can listen to reactions from the participants. First of all, let's hear from the residents. If you have questions or comments, you can. If you have comment, you can raise up your hand or you can send a question.
Good morning, sir.
Yes, good morning.
Okay, good morning, sir. I'm particularly excited that I'm able to talk today because most times where I am, the best I can do is just to send message. So I thank you for this opportunity. Thank you for your presentation, ma. Hello, can you hear me, ma?
Yes, I
Okay,
can
I hear you.
Yes. I have a lot of clarification to make because of exam, particularly on the approach. There was a time there was a presentation like this, and I think I asked similar questions. So just to be very sure that when we are asked questions like this to develop or design a screening program, if you are asked how are we going to, is it the same thing as develop or plan a program like instructive? And if that is so, ma, I was wondering if it would be important to define our aim for the program, just the way we were taught during community health program, if we are expected to set objective specifically. And I remember we also told that for that kind of situation analysis, even before setting aim and objective, we can assume figures, though we can also get from previous study and all of that, because maybe the examiner may want to see how we arrive at those things, like maybe the control targets, the ultimate intervention goal. We want to know the prevalence and magnitude of the blindness as well as the disease condition in our clinic. So I was expecting specific things like maybe to control the blindness due to diabetic retinopathy in our own clinic, maybe UATH over a certain period, and then the objective to be smart, specific, and time frame so that we can appropriately use those indicators to monitor. So I was expecting that pattern, the situation analysis, define goal, set target, then the strategies. Though essentially overall you talk about those strategies, but I was just wondering maybe it's going to be more practical to our area. Thank you very much, ma'am.
Okay.
Dr. Nwange, you want to react to that?
Okay, thank you, Dr. Lagunju, for the presentation, for the question and the comments. It actually asked if developing a program and then planning one is actually the same thing. I actually think they are the same thing. And in approaching my own question, I tried to lump the two together, whether developing or planning. I tried to look at it as the same thing. Yes, I actually had a broad aim, which I actually specified in the presentation. I don't know if you missed out on that, that the aim was actually to reduce the slight sight-threatening complication of diabetes, diabetic retinopathy in the University of Abuja Teaching Hospital. But then I actually did not set out my objectives, which actually I should have listed. Maybe SNAP, and like we all know, they said objectives should be SMART. So I should have brought them out and made them specific, measurable, and then time bound, maybe to reduce the incidence of diabetic retinopathy by 50% in patients presenting to the University of Abuja Teaching Hospital by the year 2020. And then also I could have another objective, which would have been to see the number of patients that are being treated with probably laser or anti-VEGFs in the University of Abuja Teaching Hospital, to see if there's any increase in the number that is being treated by maybe 50% from the year 2020 to 2012. So maybe I should have stated out my specific objectives and not just outside the aim which I had. I should have listed out the specific objectives. Then, okay, you said something about the strategies. I actually think I talked about them, even though maybe I did not bring it out as the way we were taught during the community I held, but I think I actually brought it out in the presentation. Then you also made mention of having to use arbitrary values. Okay, like if this question was thrown to me, if I had to take a particular maybe value for maybe the population. Yes, I know we're told that during the update course, but I really didn't do it that way. We're still open to corrections from the consultants and anybody